So when you're testing range of motion, you're always going to want to do so bilaterally. And at this point in our diagnostic, you can use a differential diagnosis to ascertain that we are dealing with an injury of either the knee ligaments or the menisci. So we will perform the rest of the assessment in light of that and do special tests which help to continue to narrow down what injury we might be dealing with. We need to know that our end range, extension, or flexion should display the most pain with an ACL tear. And also, since L3 is the spinal nerve that innervates the knee for extension, we know that it innervates the quadriceps, adductor longus, magnus, and brevis. So issues with extension may indicate an issue with this nerve, but further testing concludes that the issue is not with L3, but with the ACL. So when we're doing our range of motion testing, first we're going to start with an active test. We're going to ask the patient to sit with his legs over the edge of a table. We're going to ask him to straighten or extend his leg, and then also to flex it, bring it back down. Next, as the clinician, I'm going to go ahead and bring the patient into knee extension and flexion. And this would be bilateral if we were doing a real assessment. And then we're going to do resisted. So I'm going to protect myself by standing over on the side. I'm going to stabilize the quad, and I'm going to ask him to please extend your leg out. And I'm resisting it to feel if there's any issues with his musculature. I'm going to ask him to push up against my hand. Nice. And then I'm going to go ahead and switch hand placement, ask him to bring his leg down while resisting it. And then I'm going to ask him one more time to push against my leg. Nice. And then lastly, I'm going to go ahead and do some tibial internal rotation and ask him to push up against my nice. And then external rotation, and once again ask him to push against my hand. Very nice. And these are going to help you identify if you have some type of muscle weakness or issues with any kind of parts of the body that are dealing with extending or flexing. Next, we're going to check the range of motion for the hamstring muscles. First, we're going to have the patient actively flex his knee and then extend his knee. Very nice. Now I'm going to passively do it. He's got good range of motion. And then we're going to have resisted flexion. Go ahead and flex. Very nice. And then extension. Very nice. The patient has good range of motion. For our manual muscle testing, we're going to be able to look at the biceps femoris by bringing the knee into flexion and having the tibia in external rotation. So go ahead and flex your leg. Nice. While in external rotation. And then for the semis, we're going to have knee flexion with tibial internal rotation down at the bottom. Go ahead and flex. Very nice. For manual muscle testing of the quadriceps, you're going to go ahead and have the hip go into a bit of flexion, and you're going to extend the leg. Very nice. And then if you're going to do the sartorius, what you're going to want to do is put the knee into a bit of flexion and then go ahead and externally rotate the leg. Because of the info we have gathered during the history and observation, we have compared bilaterally, and now we should be able to feel a complete tearing of the ligament when doing special testing. This also would imply excessive motion only restricted by secondary structures such as tendons and a definite empty end feel. The best two tests that we could use for ACL tears would be the Lockman's test, which has a specificity of 90 to 100, and also the anterior drawer test, which has a specificity of 90 to 100 as well. And even a partial tear would result in some instability of the knee and have an impact on the biomechanical function of the joint. So first special test or stress test we're going to do is looking for swelling and effusion. We're going to go ahead and do a sweep test where we're going to start on the middle aspect of the medial thigh and go ahead and sweep down across the knee in a backwards J pattern. And now, although we're going to see some movement of the patella, what we're really looking for is excess movement of the fluid in the knee. And then we're going to go ahead lateral and do the same type of sweep test. Once again, the patella moves a little bit, but we do not have excess fluid movement. So first, we're going to do the anterior drawer test. We have the patient in a bit of hip flexion and knee flexion. I'm going to go ahead and stabilize his foot by sitting on it. Then I'm going to reach behind his knee, have him relax his hamstrings, place my thumbs anteriorly, and go ahead and try to extract the tibia anteriorly. And what you're looking for is excess gapping right here on the tibia where the ACL should usually prevent it. And he's healthy, so his ACL does prevent that extra movement. Next, we're going to go ahead and do the Lockman's test. Once again, his leg is extended. I'm going to go ahead and place his knee over my leg, stabilize his femur, and then grasp behind his knee, and once again try and extract his tibia forward. And although there might be some movement, what we'll discover is that there's not very much because his ACL is in place and doing a good job of keeping his leg together and preventing tibial movement. So for doing the Slocum test, you're going to do similar positioning, but instead of just sitting on the foot, what you're going to do now is internally rotate the leg, and perform the same thing that you did with the anterior drawer, or you're going to go ahead and externally rotate the foot, and then once again pull. And the Slocum test, if it's positive, is going to indicate an injury on the ACL, LCL, or the lateral or medial meniscus, depending on whether you internally or externally rotate, respectively. And then the next test you're going to go ahead and cover is the lateral pivot shift test. The patient is going to be laying back in a supine position, and they're going to have their hip flexed and abducted to about 30 degrees, and we're going to internally rotate the tibia and use the other hand to support the popliteal fossa, and then we're going to go ahead and move the leg around 30 degrees, looking for any kind of click. We've got it internally rotated, supporting the fossa. We're bending and extending, looking for a pop or click or pain. For the phalangeal stress test, we're going to go ahead and stabilize the area above the ankle, and then go ahead by the femur and exert force internally on the knee. And then we're going to go ahead and bring him up into a bit of flexion and do it once again, checking to make sure that that MCL is doing well. Then next we're going to do the varistress force, where we're once again going to stabilize by the ankle and then push out on the knee, and then bring him into a bit of flexion and do it one more time, and that's going to be checking the LCL. So for the McMurray's test, you're going to test the menisci and check for tears with that. You're going to go ahead and internally rotate the tibia, and then go ahead and bring the leg through flexion and extension, and then you can also try it with lateral rotation, going through flexion and extension. And you should not experience intense pain with this or popping and clicking, otherwise there might be a meniscal tear. In our case, we're doing an ACL injury evaluation, so this should come back as negative. Next, we're going to do a posterior drawer test, which checks for PCL instability. It's the same setup as the anterior drawer test, but instead of extracting the tibia forward, I'm going to go ahead and push down and check for extra joint laxity. And then the last test we're going to go ahead and do is checking for patellar tracking, and it's going to be Clark's sign. So I'm going to go ahead and place my hand on the superior aspect of the patient's patella, right where the quadriceps tendon is running into it. I'm going to go ahead and have them flex their quadriceps, and I'm going to press down inferiorly and medially into the leg. And what we're checking is for excess patellar moving as well as pain, which would be a positive sign.
So there is a chance that your ACL tear may actually be a tibial spine fracture if the injury occurred from a rapid deceleration or hyperextension and rotation of the knee, or trauma such as falling and hyperextending a leg, like when a child falls off a bicycle. Typically, this occurs in children from ages 8 to 14, and it results in swelling and pain and inability to weight bear, as well as keeping the knee in a flexed position, with examined effusion, limited range of motion, and positive anterior drawer. So you can see how this would easily be confused with an ACL tear. With this, you would want to refer to a radiograph or CT scan or MRI, and you would be able to clue in as to whether you were dealing with this type of injury based upon the mechanism of injury that you were told during the history. Also, a ACL tear could sometimes be confused for an osteochondral fracture, which extends through the cartilage and into the bone in that knee joint. This happens from joint compression with varus or valgus or rotational forces. The signs and symptoms, once again, are pain and swelling. However, this also may include locking or clicking. There is pain with compression and weight bearing, and there is palpable tenderness and crepitus on the joint line and the femoral condyle. The sooner the knee assessment takes place, the better the diagnosis, because the swelling won't have time to block or allow for misidentifying injuries or having false positive or negative special tests. And then finally, when you're taking a look at the rehabilitation process for a third degree ACL sprain, You really are going to want to restore your range of motion and your lower extremity strength as well as your proprioception and decrease that effusion and fluid in the joint space. And unfortunately, with the third degree, you're typically going to require surgical intervention, and this is going to use an autograft, which would be from yourself. You would harvest basically part of a tendon, such as the patellar or the pes anserine tendon, or it could be an allograft where you are going to get some tendon from a cadaver, and you're going to use that to help rebuild this portion of your knee. An accelerated rehab with early range of motion and weight bearing and muscle function could decrease your time lost after surgery. And if it's just an isolated ACL injury, then earlier weight bearing could restore muscle function in a quicker manner. I hope you learned a lot about a third degree ACL sprain and hope to see you soon.